Hello, everyone. This is Dr. Afrouz Demeri, naturopathic doctor and director of functional medicine at University of California, Irvine Susan Samueli Health Institute. I just want to go over some of the research articles I've been reading and some facts for you guys, especially my medical colleagues who are interested in all the research and want to kind of geek out with me. So, there are four common types of coronaviruses. They can cause colds. I'm just reading all my notes here, so looking down from my Instagram, there's three bad ones. There's the SARS coronavirus that causes SARS. There's the SARS coronavirus 2 that causes the COVID-19 that we're dealing with right now. And then there's the MERS coronavirus, which causes the MERS. Where did all this start? Where did it come from? There's lots of speculations out there, but most likely bats. Did it spread directly from bats to humans, or was there another species or animal in between? We can't know 100%, but there may have been an intermediate animal. And are these things seasonal? So there's some talk about with temperature, with this going up, and summer coming up for us, that this is going to improve. But they did look at this and what can we expect. And you will see that in January and February, there was a huge peak. So hopefully this means that with summer coming here in California, that things, once they do warm up, that this will go down. So yes, there does to be some correlation that this is seasonal. What do we know about immunity? So we do know that repeated infections occur with common COVs, and there's short-lived antibody protection. If they're really mild cases, so if someone has a very mild case, they don't have a lot of symptoms, then you don't necessarily get a lot of antibody response and protection. SARS antibody titers greatly reduced after 3 years. And if we look at IgM in the blood, so people who are asking me about blood tests, IgM is when you have an immediate reaction, right? And you currently have it. IgG is more like a past exposure. So they saw that about 4 to 5 days after the IgM, the IgG responses were up, but we don't know that how long that IgG response will last for. So usually, for example, if you've had mono in the past, like Epstein-Barr virus, and we test you now after 20 years, or you've had a vaccine, the IgG stays elevated. But with this, we really don't know how long the IgG will stay elevated for. The good news is they looked at 2 to 3 monkeys who were re-exposed to SARS-CoV-2 after recovering from COVID-19, and they found that they did not get reinfected. So that's good news, although it's only 2 or 3 monkeys that were looked at. And anecdotal reports of current COVID-19 recurrence is sort of erroneous. So there's probably a lot of false negative testing. So we don't know too much about that. Are there vaccines against this? Several are being tested in animals against MERS and SARS-CoV, inactivated ones, DNA ones, and then currently, obviously, there's a new vaccine that's mRNA expression of the spike proteins that are just rolling out. What is the pathophysiology? So, as I've said in past videos, it attaches to the pneumocytes in the lungs, and the alveolar macrophages are infected. There are cytokines like interleukin-6, TNF-alpha, interleukin-8 that are involved, macrophages, neutrophils, delayed but persistent interferon, and often fibrinous pneumonia. That was in SARS. So in the US currently, there's been 16,000, this was as of yesterday when I checked, over 16,000 cases. and 121 recovered, 74 deaths in Washington. In Orange County right now, or as of the 20th, yesterday, there were no deaths. There's 65 cases, and I believe we have one extra one today at UCI. So that's good news, I guess. No deaths here. How does this present? So the incubation period, we were told usually for 14 days you wouldn't have any symptoms, but typically the mean, as I said, is about 4 to 5 days. So symptoms usually start within 4 to 5 days, and majority, more like 80%, are very mild. They kind of have these flu-like symptoms that resolve on their own within 1 or 2 weeks. Some have progression to severe or moderate pneumonia, and about 15%. This is from 4 research articles that I'm looking at: Zhangkao Li, 2020, Wu et al., JAMA, February 2020, Chen et al., 2020, February 11th, and Zhu et al. In the Lancet, 2020, February 18th. So this is where I'm getting this data from. In second week, they had sort of a mild pneumonia, and then most of the data available is, as we know, from hospitalized patients. So about 20% of the hospitalized required ICU, and they had 17 to 29% had respiratory failure, and some had septic shock. So signs and symptoms, not everyone will get a fever, and not every single person will have the cough and respiratory symptoms. Most will, but we have some cases here where it's just digestive and they were confirmed. So it can really, really vary. Fever, we see about 77 to 98%. It can be prolonged and intermittent, so it can come and go. You can see a cough. Often it's dry and non-productive. You get that, body ache and fatigue and feeling really run down. 3 to 31% had that shortness of breath. And less commonly, we see sore throats, headaches, and like I said, nausea and diarrhea, which is a case we had here at the hospital. So just GI symptoms. I believe she had nausea, vomiting, and fever. So it can look like a stomach flu, What else? It's uncommon to have sneezing or runny nose. Obviously, if there's shortness of breath, you absolutely want to, look into that. What about asymptomatic infections and spread? So there are also a lot of people who are carrying this around who are asymptomatic. There have been well-documented, looking at Carrot et al., American Journal of Epidemiology, 2008, and Petruzzo, Public Health, 2009. We see this in influenza, 1/3 to 1/2 are asymptomatic. We see this in measles, pertussis, Neisseria. Majority of the children, young adults, thought to be significantly less likely to spread. What about majority of the confirmed cases versus suspected versus clinically diagnosed versus asymptomatic? So if you look at the novel coronavirus pneumonia emergency response epidemiology team article from China, 2020, accessed February 20, 2020, I'm looking at how many you'll see confirmed cases and the dates they have, which starts around the 11th of January, and how many are asymptomatic. Most are confirmed, some are suspected, some clinically diagnosed, and so that's interesting if you guys want to look at that article. Report of the World Health Organization China Joint Mission on Coronavirus Disease 2019, looking at the final report February 16 to 24, 2020, looking at the initial epidemiology curve. Thousands of symptomatic patients were undetected because they showed up and none of them had any kind of coverage or social distancing, obviously, and all of them were carriers and they didn't know And even the healthcare providers didn't know. And then they're all in these beds, breathing everything in and didn't know. So this is how it spread so quickly. And there were no personal protective equipment for them at that time. So if you look at actually the pictures of in China, these people that are just in the waiting rooms, just thousands of them, and nothing to protect them. So how infectious is this? And the New York Times, February 7th, did a beautiful graph on this. And you'll see that chickenpox, ranges, I'm just looking at the an XY axis here, is around 8. But probably the most infectious is measles as we know it. But so it's called the reproduction number. For this, it was 2.35, but then it decreased to 1.05 after the travel restrictions were put in place. So that's, it slowed down the spreading, which was nice. So where is this has this been detected in the body? So we call it PCR testing. Where they're looking at the actual DNA. The respiratory is where most of this is detected. The viral shedding is greatest in this area, highest in the pharyngeal samples and highest in the first week of illness. Blood, we are not detecting it well there. And urine, we are not. But stool, we are. You're seeing high viral RNA counts. Not viable virus are not found there, but it is being detected there, dead or alive, which is why most often now you'll see the testing is a nasopharyngeal sample is needed. It's nicely put in the article in JAMA, March 11th, 2020 by Wang. You'll see a nice graph of the pharyngeal swabs. When the cycle threshold reached 40, you'll see all of the ones above there. They looked at feces, sputum, blood, nasal swabs, urine, and pharyngeal swabs, and bronchial alveoli lavage fluid. So what is the clinical significance of this positive PCR when you're assessing the transmission risk? So the COVID-19 PCR detects this viral RNA, but cannot tell us if this is viable. So, for example, we do see C. diff in the stool, influenza, RSV. These can be positive for weeks after clinical infection resolves. But in the stool, for example, when they looked, there was no viable virus found, as I said. So not possible to translate detection of this virus in the body fluids to ability for transmission is what they concluded. Risk factors, we pretty much know this. Anyone over the age of 70, immunocompromised, having issues with their lungs, heart, cancer, liver disease, on drugs that suppress the immune system, autoimmune patients who are taking things like that. The case fatality highest were in China, there was 1.4% for surveillance, and hospitalized 2.3%. In South Korea, when they started really testing, this went down to 0.6%. The calculations that were made looking at the mortalities highest where they were worldwide, China, Italy, Spain, and California, we had 870 cases, 16 deaths. So percent mortality is 1.8% currently. What lab abnormalities are most common? This I find very fascinating. The article is Huang et al., Lancet 2020, and Chen, Lancet 2020. So amongst hospitalized patients, most common lab abnormalities were lymphocytopenia, so low lymphocyte counts, and white blood cell count can be high. So leukocytosis, there was 24 to 30%, or low leukopenia, 9 to 25%. Elevated ALT, AST, I've seen this in a couple of the patients. 37% had this, or liver enzymes were high. Thrombocytopenia, 36%. Serum procalcitonin is normal in most. So some of this actually looks a lot like EBV, Epstein-Barr virus, which is really interesting. Zhu et al., Lancet, March 9, 2020, has the days from illness onset and then the lymphocyte counts So very fascinating looking at survivors versus non-survivors. Um, so the coronavirus in the cardiovascular system, we know that there is a huge problem in how it affects the heart and hypertension, confounded by other diseases, diabetes, and such. And there is some debate right now amongst, interestingly, I have lots of cardiology friends, and some are listening to the American, obviously, the Heart Association, the American Board of Cardiology, is saying not to take anyone off anything. Obviously, it's also a liability issue. You do not want to start messing with meds and taking people off things without really having a valid reason and some real data and proof. So make sure, if you've heard, even I've said that, the theory makes sense in animal models where the ACE2 receptor expression can increase with some of the medications that you might be on. You really want to be careful and not take medical advice, from me through Instagram or Facebook, and speak to your cardiologist and your doctor and see what would be the best course of action for you if you are at risk. So other viruses that are known to have cardiac impact, there are many, but we do know that viruses do affect the heart and they cause acute myocarditis and injury to the heart and even arrhythmia and heart failure. Testing. So in the ideal world, we would be able to test everyone who has symptoms. Unfortunately, here there are shortages and clinical judgment is really paramount, and we are not able to test everyone. So the criteria has changed for me personally, as I'm wanting some of my patients that have classic symptoms, and not everyone is getting tested. So testing capacities are still limited. Swabs are not available the way we would want it. Staff personnel, the time it takes to process these samples are taking 6 to 7 days now. So in an ideal world, it wouldn't be like this, but we're doing the best we can with what we have. And then what treatments are being considered right now, largely, I wish someone would fund and we could patent some of these natural herbs and, study IV vitamin C. There's lots of reports I hear are coming out. They've just been written up on their use in China and how much they helped 10 to 20 milligrams of vitamin C. It's not published yet, so I'm not going to quote it, but interestingly, there are things that we can do naturally too that help the cytokine storms and are anti-inflammatory and reduce IL-6 and IL-8. There's research on many things on those things already. However, currently, when there's such an acute state, to get an IRB and NIH and all that involved to quickly study these things, it's very difficult. So right now, the investigational therapies largely are remdesivir, which I mentioned last time, and which is a broad spectrum antiviral, chloroquine or hydroxychloroquine antiviral, and inhibits that cytokine storm. The IL-6 inhibitors, favipiravir, the RNA polymerase inhibitors, and Kaletra, which I mentioned, which I think is showing no benefit in the recent randomized controlled trial. So this is from CAO et al. March 18th, 2020, and Liu Cell Discovery 2020. What about asymptomatic infection and spread? So asymptomatic infections have been well documented in many viral syndromes and infections like influenza, measles, pertussis, as I mentioned. So most of them, as I mentioned, are kids and young adults who are carriers. So I'm just going to leave it here. Hopefully those facts were helpful in you just learning more about this, and that you're seeing that, especially here in California, things are hopefully anyways not as bad as I thought it would be. And the social distancing and staying home has really been helpful. So please continue doing that. And yeah, really, really, really consider that it's not for just your health. And most likely, this is not going to cause death for you per se. If you're watching this like me and you're like, I'm fine, it's more that you could carry this and predispose it to someone else who doesn't have your immune system, who is elderly, who um, this can be detrimental for them, and also it's going to spread it. So that's the issue. So please don't just think about yourself and whether this is going to harm you and your family per se, but that we need to do this for everyone around the world, and especially those who are at risk. All right. Thank you for listening, and I will try to keep these updates going every week.